Hi, this is Shirley Gutkowski of Crosslink Radio. Welcome to the audio-visual edition of Crosslink Radio. I wanted to take a few minutes to talk about something that came up recently in a course that I was asked to give. I was asked to give a course on CAMBRA. CAMBRA stands for Caries Management by Risk Assessment. And what I thought they were asking for was a comprehensive course about caries management by risk assessment and ways to mitigate the risk. And what I learned when I arrived was that they were hoping to have a fluoride course. Somehow there has become a focus on fluoride that ties it into this CAMBRA notion that is really underrated, or it's underappreciated or under-evolved. Maybe that's it, under-evolved, because CAMBRA is not about more fluoride application. That was just the first step of CAMBRA. To give you an idea of what CAMBRA is, back a few years ago, probably 2004 or 5, the dental department at UCSF was, I don't know if he wasn't the dean at the time, but he had something to do with the dental schools, a researcher named Dr. Featherstone. And he got together with some other dental school leaders, and they came up with a plan that was intended to teach dental students a new way of approaching dental decay. That they were not addressing the reason for dental decay. Students weren't. They were not being taught how to address the reason for decay, and they were continuing on a pathway that had either gone the wrong way or had been beaten in the wrong direction, or it wasn't working any longer. People were keeping their teeth and they were getting more and more fillings, but nobody was addressing the reason for the fillings. So UCSF and University of Pacific and some key players were Dr. Featherstone, Dr. Young, probably a pile of others who I just don't remember at this point. And what they did is they reimagined the way that dental students were taught. That before a dental student was allowed to do a traditional filling, they were asked to address the risk, to assess the risk for future decay, assess the risk for their fillings lasting, and assess the risk for a good outcome. And that kind of spoke to me because of my friend Renata, who I went to high school with, who was treated for oral cancer. She had cancer on her back, I think it was a lymphoma on her back that metastasized to the base of her tongue. And so she had radiation treatment to the base of her tongue, which of course took out all of her salivary glands. She had no saliva whatsoever and no money for dental treatments, as her teeth were crashing one after another. And what I could do was very minimal. I wrote a couple of articles about her condition into the magazines, and then I sent her the money that I earned from those articles, which was nothing really. And I also strongly suggested that she go to the dental school at Marquette. And the dentist, the little dentist boy, was over his head. He was way over his head, and he would do nice little fillings, around on all of these teeth. Every 3 months, she would come in for a new round of fillings in 1/4 of her mouth. So every year, the treatment plan was to replace all of the fillings once a year. How does that sound to anybody? That sound terrific? But, he didn't know any better. I didn't know any better. We didn't have products like what's offered today for remineralization. But what really corked me the most was that this poor little dentist boy was doing the best he could under the circumstances, and his overseer, the dentist who was in charge of the clinic that day, berated my friend Renata for not brushing and flossing well enough. That was so over the top, I couldn't believe it. No one was addressing her risk, and they only applied one option, and that was all on her to create a situation where she would no longer have decay. Well, of course, that's not true. Once you have no salivary components at all, there's nothing you can do to save your teeth that doesn't include outside help. You cannot do it alone. There's nothing you can do alone. So I want to make sure that that part is driven home, because that fits right in with this CAMBRA thing. So what CAMBRA did then was kind of focus on ways to mineralize teeth and make teeth harder so that they would be more resistant to decay. And that is what fluoride does, makes your teeth more resistant to the acid challenges that are inevitable. But fluoride really needs other components in order to work properly, and those components come from saliva. If you don't have saliva, there's really very little that fluoride can help you with. Does it hurt? No. Does it help? Not as much as most clinicians seem to think it does. So now I'm at this course, and now they want to know about this fluoride, and they wanted me to like hammer on this. How many cavities did somebody have before you put this much or that much fluoride on their teeth? And I'm like, this is not what CAMBRA is. It's risk assessment for caries management. That doesn't mean when to apply fluoride at all. And I think that they've kind of dug themselves into a new hole. That they used to teach dentists how to approach dental decay by providing the tooth with, a filling, and then put some fluoride on it, and then hand them over to the hygienist to whip them with a piece of floss. That's not fair. That's not at all what I perceive CAMBRA to be. If we are going to be assessing the risk, then we have to be open to things that are going to mitigate that risk. And that's why the CAMBRA model with fluoride is just a tiny first step. So what I did was I reported on a number of other options to reduce the oral biofilm. Fluoride does very little for the biofilm or against the biofilm. There are a few studies to show that this kind of fluoride or that kind of fluoride does this or that certain thing, but nothing like what can be happening if we were to start really looking outside of fluoride and other options. Xylitol is the number one thing right now. The CAMBRA model does incorporate a little bit of xylitol. I don't know that they go far enough. Xylitol and fluoride together will work really, really well. There I go again. Xylitol can help stimulate saliva. Most of the CAMBRA applications have been towards children who have plenty of saliva. So what do we do with a 60-year-old person or a 45-year-old person that has one of, tens of hundreds, thousands of potential diseases that dry out the mouth or medications that alter the composition of saliva? Nobody's looking at saliva. Saliva is a key component here. Xylitol stimulates a little bit of salivary flow. It stops the early colonizers from building the plaque matrix, and so none of the biofilm can really survive under those circumstances. It has no way of being created. So that is what my whole talk was about at that venue. And so I talked a lot about coffee. I talked about licorice root. I talked about erythritol. I talked about chewing gum in general. I talked about, I don't know, I talked about a lot of different things. And then, you know, everybody had kind of a long face, but it was the end of a long day, you know, for them. And for me too, I got up pretty early to fly over there and then, well, to drive over there, to fly over there, to drive over there, then to drive back to my hotel, which was near the airport, and then to fly back home. So anyway, it was a long day for everybody, so maybe that has something to do with it. But when we're talking about CAMBRA, we have to stopping at fluoride, because there's more to it. There's more to the risk assessment, and there's more to mitigating the risk than just applying anti-dissolving minerals to the enamel. And that's why products like MI Paste and Remin Pro and Novamin are so important for our patients. And Xylitol and erythritol and diets that have been the foods that you see listed in an anti-inflammatory diet, or I just watched a TED Talk on an anti-cancer diet. All of those foods also reduce the oral biofilm. It's crazy how it's the same list. So all of those things that you read about are for anti-inflammation and anti-cancer, that include green tea, they include the berries, they include coffee, I remember seeing on the list. Tuna was on that list, which is very unusual. Most of these lists don't have any meat products on them at all, mostly because meat's not studied. Meat has a bad reputation. I think we're going to be very sorry that we didn't look into meat more. So anyway, we have a lot of other options. And one of the problems with the risk assessment part is that we don't know about our practices. We don't know the risk of our practice for either attracting or attracting disease, or solving disease, or curing any diseases. So I was looking for some information for an entirely different topic, and I stumbled across my study that I did, my survey, I guess is more accurate, that I presented for the World Congress of Minimally Invasive Dentistry a few years ago. And their motto, the World Congress of Minimally Invasive Dentistry's motto is, "There's no filling like no filling." So that is another thing that really spoke to me, and it really just has to be something that we think about dramatically all day as clinicians. And when you are a patient and you're coming in, I think it'd be well worth your while to really sit up in the chair and have a conversation with your practitioner, if it's the hygienist or the dentist, and talk through some of the things that they know about or should know about to reduce your chance for cavities or for periodontal disease. So what I found is that these people don't know squat about their practice or their patient base, and so I wanted to put this together in a way that was easy to present to the World Congress of Minimally Invasive Dentistry. And I thought this would be good for a video section for Crosslink Radio, to kind of let everybody know that we don't know what the risk is in our practice, and that we don't really know what to do about those risks. So I sent out, I was belonging to a group of dental hygienists. There were 4,000 members. She tried to keep it clean so that there weren't too many industry people in there. And I didn't have a lot of respondents. I had a short timeline, and you don't want to leave these surveys open forever. But I had 61 respondents for this question: how many patients in your practice have periodontal disease? Look at the don't know. Only 10% of this group, only this large green section here, thought that 10% of their patients had periodontal disease. Over that tiny light blue area in the middle, thought that over 80%. The little darker blue section there to the right thought that about half of their patients had periodontal disease, and then the purple area there was the number who thought that 68% of their patients had gum disease. That's a lot of what? Nobody knows how many people have periodontal disease. We have no good diagnostics for periodontal disease. That's another topic for another day. They didn't know how many of their patients with periodontal disease also had cardiovascular disease, or how many of their patients had cardiovascular disease, or ever thought to sit down and put the two together. So that's another big hole. If we are of the mindset, and we in dentistry have a really good understanding that health comes from the mouth and that periodontal disease impacts the cardiovascular system, you would think we would know that. We would know how many of our patients had cardiovascular disease and how many of those have periodontal disease and vice versa. 51 respondents answered, how many of your patients have stroke? Look at that, not applicable. What does that even mean? Most people don't know. Some people thought somewhere between 2 to 5% had stroke. They don't put the two together with periodontal disease in their practice, even though we know that there's a pretty tight correlation there. 61 people responded to the number of patients with diabetes. Over 10%, 38% of the respondents thought that over 10% did. 13 respondents thought that somewhere between 5.5% to 10% did. 7% thought that 5% of their population, their practice population, had diabetes, and 42% just didn't know. 52 people responded to the question, how many patients have oral cancer? 48% said somewhere between 0 and 1%, even though we know that that's absolutely does not match with the population in general. 42% of those 52 people didn't know at all, and 12% thought that somewhere between 2 and 5% had oral cancer or experienced oral cancer. Compared to other offices and compared to others in the office, how do you compare in chart notes? I wanted to see how arrogant these people do, how backslappy they are. And 74% thought that they did more, that they wrote more in the patient notes than the rest of the office staff did. So that was kind of funny. New patient exam, blood or saliva test. Nobody really did that. 13% did diabetes. 13% did C-reactive protein. 20% of this small group here did a periodontal test for saliva. Caries, 34%. HPV, which is the oral cancer virus, 20% said they did HPV test. What do you chart on new patients? Which was really kind of surprising. Only 42% did a perio chart. Only 33% charted existing restorations, and 19% charted occlusion. Only a tiny sliver, 6%, charted sleep apnea, or even looked at sleep apnea. Where do they chart? Which is a big sticking point for me, because dental hygienists have a lot of responsibility, as you can see as I'm going through these questions. But they have nowhere to sit to think. They have nowhere to put pieces together. They have nowhere to sit to even create a chart for their patients. 51% did it on the counter in their treatment room. Over half. 41% in their treatment room on the computer. And 8% chose other. Do you practice minimally invasive dental hygiene? Not many people knew what that was, I don't think, because I got a lot of comments about that. 45% said some. It's not a very good question. 28% said that they do practice MI dental hygiene. Only 10% admitted to not being sure what that was. With respect to caries management, how are you treating it in your current practice? 85 people responded to this question, and most people said fluoride and intensive oral hygiene. So it's still about fluoride and badgering the patient and blaming the patient. With respect to caries management, how are you treating it in your current practice? 45 people of the 85 said that they were using calcium phosphate products. So a little over half, so that's great. 31 people reported that they were recommending xylitol and functional foods. So that's not bad either. Needs to be higher. 28 people reported dietary evaluation and making adjustments. To tell you the truth, mostly the adjustments are getting rid of soda. 32 people of the 85 reported a shorter recall. That means they had people coming back not in 6 months, but maybe in 4 months or 3 months. If you have a lot of decay on your teeth, you should be coming back within weeks, not within months, just so you know. I also asked what kind of hygienist they were as a practice management person. The practice of dental hygiene is not only directly opposite from a dental practice, it's part of a dental practice, but it should have its own leader. It should have its own champion to kind of run things and be a liaison between the rest of the dental hygienists, or just that hygienist, and the dentist or practice manager. So I wondered, do they ever call a meeting? I was very happily surprised to see that almost 60% of the dental hygienists of the 85 said that they did call a meeting. I'm going to say that one more time. 85 people responded to this question. 59% of that 85 number said that they do call a staff meeting. So that's great. I asked how are office meetings handled. 27 people said that the meetings are set by the practice owner or practice manager. 5 people said meetings are on the fly. 36 said that they have called a meeting with the dentist. Does your practice build relationships with physicians? This has been really, really challenging and difficult. And what nobody wants to talk about is that it's the language that we use that doesn't match medical language. When a physician talks to a patient, it's over the patient's head. When a dentist talks to a patient, it's right at the patient's head. But when they talk to one another, they very often are still at that same level. I'll never forget a practice manager person came and talked to us at the World Congress of Minimally Invasive Dentistry, and he was mad that there weren't more ties in the room, that people were not dressing like professionals, that they were all casual at that meeting. So I wondered who in the office was doing it, whether it was the hygienist or not. 35% said that the dentist visited with a physician. 10% said that they wrote their own letters to the physician. 5% said they were just too busy. Only 2%, but yay for 2%, said that they met with a cardiologist, and 48% said that nobody had taken that up at all. It was not even anywhere on their agenda. I'm wondering what that would do now if I asked. So anyway, those are the kind of questions that I was looking forward to having better information for as I presented it to the World Congress of Minimally Invasive Dentistry. We clinicians, we hygienists need to know how many of our patients have diabetes as a whole, whether or not those patients have cardiovascular disease, stroke, diabetes, sleep apnea. Sleep apnea is a missing component here. We can be doing so much more with our sleep apnea patients. I'm learning so much about sleep apnea and how to breathe. If you'll go back through some of the archives here that we have at Crosslink Radio, you will find a couple of interviews with people that are breathing retrainers. So what they have taught is how to reset your respiratory centers so that you don't overbreathe. Overbreathing is a condition that is partly brought on by facial development, partly brought on by society, and partly brought on by not knowing better. That we think that we have to breathe all the way down, deep breathing is the best and all that stuff, when that's really not true. Deep breathing should be like a cleansing breath, but it should not be every breath. And even when you're exerting yourself, you should only be breathing very shallowly into your lungs, and it should be silent. All breathing should be silent. I talked to a woman last week I didn't talk to her, it just kind of came up in a group conversation that her 18-month-old baby was kind of a fussy eater, and she was kind of running around all the time, and she wouldn't sit down, and I think she said one other thing, and I thought, boy, that baby sounds like they have sleep apnea. And so I called her, and I talked to her, and one of my top questions was going to be, does your baby snore at night? And then she told me on her own that her baby snores, and that she just shared a bed with that baby, I don't know, within the last short while, and noticed that the baby often stopped breathing. And I said, oh, well, that's sleep apnea, and you need to get that baby evaluated like right away. Oh, I know what it was. She was petite. She was very, very small. So all those things together set off an alarm in my head. So all of these things are things that all hygienists should be knowing about and all dentists should be aware of. And this is why this kind of information and the conversation that I had with her really kind of makes me even more desperate to get out to consumers so that they can really demand more of their clinical dental practice people, and how we need to really strive to get out to our consumer listeners, and we have to give them something besides another fluoride lecture or another fluoride sample or application, because there is more to it than just that. And they need to know that. And they need to be the ones who are going to drive dental hygienists to be better clinicians, better practitioners, which will, in turn, make it easier for dentists to go, hey, maybe we should have hygienists out, not just in a dental office. And for legislators to say, dental hygienists really saved my dad or helped my dad out when he was going through his heart attack treatments or whatever all. And that's how we're going to grow dental hygiene out as a practitioner out in the world. We have a lot of problems in dental hygiene as an industry, and we can do better, but we have to let people know what we're capable of. And if we're just capable of telling them how to bend floss around their teeth, or if we're only capable of applying fluoride varnish, and if we're only capable of telling them that they need a crown or a root canal and getting them to come back, that's not what we do. That's not what we do. We did not go to school and spend tens of thousands of dollars on our education to do that. There's more to what we can help our patients do. And that is why I'm offering the guided mastermind for dental hygienists, so that we can take one single topic like periodontal disease and marry it to diabetes first. That's our first 1 month mission, is to all get together and talk about what's happening at their practice, so that we can get some kind of coalition together to manage diabetes and periodontal disease together in the practice. So that is why I have developed this mastermind, so that we can all come together to some kind of a conclusion. It's guided by me, but I'm not there as the pontificator. There is a lot of things that other people bring, and other people are very, very intelligent about, and maybe they're just having trouble getting it across to their dentist or their practice manager about how important this is. And so that's why this mastermind idea, I think, is going to work a lot better, because it's not just me being a consultant. I'm not just there trying to make the doctor more money. I'm trying to get hygienists to understand how to help their patients be healthier through dental hygiene and fan out into other healthcare providers as well. So those are the things that I was bringing to the dental hygiene community and to the consumer community. So if you'd like to know more about the Guided Mastermind, you can reach me at Shirley at crosslinkradio.com. If you'd like to know more about having me come and speak to your group at Leche League or a diabetes group, or raising children's group, play groups, all of that kind of stuff, I'm really, really excited to bring this kind of information to everybody. It doesn't belong just here in my office and in my head. There's a lot of practitioners who are practicing at this level. There is no reason for you to be stuck with the practice that you're at if you're not getting what you need there. So there you go. I'm happy to answer any questions and come and speak to your group, whether by webinar or in person. And I look forward to hearing from all of you. Please take a few minutes, if you're listening to this on YouTube or if you're listening to this in your car, to please go back to crosslinkradio.com and subscribe to the site. For some reason, those numbers seem to make a lot of difference to powers that be, and I hope to be able to show people that people have an interest in this kind of information and these topics. That's it for Crosslink Radio today. This is Shirley Gutkowski signing off.